Hello everyone, this is Dr. Sandeep Badan. I am anatomy faculty at DAMS. So first of all, I welcome all of you to this wonderful field of medicine, right? This has been your dream since long and you have really worked hard for it. And now that you have achieved, my heartiest congratulations to all of you. And we all know, dear friends, that with great achievements comes great responsibilities, right? So because now this is a field where we deal with the human lives, right? So you have to really be sincere, you have to study hard, and you have to really work hard also, right? So my dear friends, we all know you will be graduated as a medical doctor, you will be practicing, you will be a renowned person, but always remember there is a difference between a doctor and a good doctor. Okay, like what is the difference? Like everyone is a doctor, that's fine. You see, even if you see in your locality, all the doctors will not have the same name or fame, right? So what do you really want to become? Obviously you want to become the most famous doctor of your town. So to become a good doctor, basically we have to work hard really, right? And there's a difference between a conceptual learning versus rote learning. So uh, when we are dealing with the patient, we must know the human anatomy, human physiology, everything. Our concepts should be clear, right? And now is not the time to go for the rote learning where we are going for the rectification, where we don't know the logic behind it, we don't know the concept behind it, and we are simply mugging it up. No, mugging up will not help, dear friends, right? So let me just share this part with you. Like mugging up is just like getting this information, someone is throwing the information, you're trying to gulp, gulp, gulp. So it will no longer work for you. In a short term, it may help you, right, getting the marks. But we are here in the field of medicine is not only for the marks, right? We have to deal with the human bodies. That is our aim, right? We have to learn. We have to learn really well. Okay, dear friends, and also now this is something very, very important for us that we have the CBME curriculum given by the NMC, right? So at DAMS, we are following the CBME curriculum given by NMC, and we are taking classes which are tailored according to the next regulation, okay, which focus on the applied aspect of the basic sciences. So the questions or the concepts of the basic sciences will be learned, but those will be learned in an integrated manner, right? How it will be learned, or how we should learn actually in a conceptual manner, let me explain, right? We all know that we will be going through this D hall for the gross anatomy. We have to learn the gross structures in the D hall, right? And also along with that, from the macro level in the D hall to the micro level in the histo labs, we will be looking at the slides, the tissues under the microscope. We will be looking here, right? You can see that. And also along with that, we have, like, you can see the skeleton. We have to study the osteology part, right? We have to study the osteology, histology, embryology. So these are the different parts of the anatomy, and you will be going through all these parts. But the thing that I was explaining, the conceptual learning versus rote learning, what is the difference? Let me take one small concept with you guys, right? Here we can see this is the scapula bone, where you can see the anterior part of the scapula, and here in this part you can see the posterior part of the scapula, where we have the spine, that is the dorsal aspect, posterior part of the scapula. Now regarding the terminology, you will come across certain nerves, like we have subscapular, we have suprascapular, we have dorsal scapular. But why those terminologies have been given? Let us look at the basis behind it, right? So dear friends, when our ancestors were quadrupods, we all know that eventually we took the erect posture, but since the beginning we did not have the erect posture, right? So when our ancestors were quadrupods, at that time we had the scapula in this orientation. Now what is the importance? When we had this type of orientation, that time the nerve which was coming below the scapula was named what? That is subscapular. And the nerve which was above the scapula was named what? That is suprascapular. But later what happened? We took the erect position and the scapula came in this orientation. When the scapula came in this orientation, the nerve which was below, now it is above. It is in front. The nerve which was below, now it is in front. The nerve is in front will be termed as the same subscapular because the name is retained, but the position is now in front. Are you able to follow this? And in a similar manner, the nerve which was above was termed suprascapular because supra is above. Sub means below. So it is below the scapula, we are calling it as subscapular. It is above the scapula, we are calling it as suprascapular. But now the nerve position is in front and behind. So in front is subscapular, but behind is the suprascapular. Could you understand this? So we don't have to mug up really that is subscapular, suprascapular. We have to have the orientation that the scapula was like this and we took the erect position, and now this is the final position in our body, right? So subscapular will be in front, suprascapular will be behind. Okay, and we have one more nerve which is having the word scapular in it. Where is that nerve? We will come to it, that part also. But just before that, let me show you this suprascapular nerve, because here we have the spine, how it will be coming in the lower part below the spine. To show you this particular part, I will take the help of this diagram. This is where we can see we have a notch, that is suprascapular notch, and one more notch I would like to show you. This is the notch. This is called as spine of the scapula, which you will eventually learn. This is a part of the scapula, spine, and this is called as glenoid cavity, where we have the joint. So between the spine and the glenoid, we have a notch. This is called as spinoglenoid notch. So like, what is the point of learning this notches? Let me show you. This is the scapula in the 3D orientation. Now first you visualize. First you see the scapula in the 3D, and let me also show you here that when you look at this part, our suprascapular nerve will come from this notch, suprascapular notch. It will supply above the scapula part, above the spine part. So supraspinatus is the muscle name. Above the spine, supraspinatus. And this is the notch. From here it will come down, it will come below the spine. So below the spine is infraspinatus. So obviously it will be supplying in behind the scapula. That's why it is called as suprascapular nerve. But now you can realize that how it is supplying above the spine and how it is coming below the spine. I hope that part is clear. Let me show you the same thing in the still picture. So in the still picture, you can see this is the suprascapular nerve coming, supplying the supraspinatus, and then it is coming down and it is supplying the infraspinatus muscle also. After having understood this part, as I said, there is a third nerve also which is having the word scapular in it, right? So here you can see this is the medial aspect of the scapula. Let me show you which muscles are present. So when we discuss this part of the body from behind, we have the huge muscle latissimus dorsi in the lower part. In the upper part, we have the trapezius, correct? And if you dissect the trapezius muscle and you reflect below the trapezius, you can see the scapula bone and these muscles which are present in the medial aspect. Okay, towards the center we use the term medial aspect. So it is in the medial aspect. Okay, and here you can see the name of the muscles are levator scapulae, rhomboideus minor, rhomboideus major. Eventually you will be learning all these terminologies, all these names of the muscles, but for time being we can understand these muscles are present in the medial aspect of the scapula. Now what is the point of knowing that they are present in the medial aspect? Because we don't have to mug up. We know that there is a nerve which lies in the medial aspect of the scapula. The name is dorsal scapular nerve. So when you have this much orientation, obviously you can say that this nerve is the one who is going to supply these muscles which are present in the medial aspect. Yes or no? So we don't really have to mug up. We have to have the orientation, dear friends. That is what is the difference between the conceptual learning and the rote learning. Eventually we have to remember the name of the muscles and the name of the nerve. But what we are doing, we are first understanding it. That where is the position? What is the name of the nerve? Why so? Are you understanding? And if you learn this way, you don't have to mug up. What is the rote learning is, we don't know the concept, we are mugging up. Second way is, we are first learning, we are first understanding, and then we are remembering. So understanding and remembering is way better than the rote learning. Are you able to follow this? Now, dear friends, what I have just now told, let me give you the summary. This is the nerve where we can see subscapular nerve supplying the subscapularis muscle, because subscapular is again in front of the scapula. Okay, that concept I have already told. It was below, now in front, so that's why the name is subscapularis. Suprascapular nerve I have told in detail, the supraspinatus and infraspinatus. These are the name of the muscles. For time we don't get worried that what are these names and all, but just to give you the idea that this is how we will be studying. Okay, and the dorsal scapular nerve will be, you see, supplying the rhomboideus major, rhomboideus minor, and the levator scapulae muscle. Okay, now that we have understood this part, let me talk about one more area in the upper limb, and I will suggest that this again, the action of the muscle, you don't have to mug up. You can yourself tell that what, according to the fibers direction of the muscle, we can think that what should be the action of the particular muscle, right? So right now what we are looking at is a cuff. It is called as rotator cuff. Rotator cuff is present around the capsule of the shoulder joint, where we have four muscles, right? We have subscapularis muscle in front, we have supraspinatus, infraspinatus and teres minor. These four muscles, the tendons of the muscle are present around this area, right? Now what is the importance? As I said, as per the direction of the fiber, you can easily think what will be the action. For example, if I show you the individual muscles, this muscle is coming from above the spine, that's why the name is supraspinatus. And this muscle is coming from below the spine, that's why the name is infraspinatus. Both supraspinatus, infraspinatus are going to the humerus, the greater tubercle, one of the part of the humerus, okay? And here what you can see is the teres minor muscle coming from the lateral aspect of the scapula. Then you have this muscle which is coming from front of the scapula. That's why the name is subscapularis. I hope now you are able to appreciate why the subscapularis has been named so, right? You remember below and in front, the same concept is applicable here. So subscapularis is going to the lesser tubercle of the humerus, right? Let me now show you all the four muscles together. So what we can see that this is the subscapularis from front. We can see the supraspinatus above, infraspinatus and teres minor. Now these muscles are present around the humerus part, but as per the action, how can we think? Now if the muscle is pulling from front, the muscle will be able to medially rotate because the arm is getting rotated inward. So this is called as internal rotation or medial rotation. So when the final resultant pull of a muscle is from front, we can say it is medially rotating the arm. But if the final pull is from behind, then it will be laterally rotating the arm. Are you able to follow? So final pull is from front, medial rotation. Final pull is from behind, lateral rotation. Now apply this principle here. We know the subscapularis muscle is in front. So if it is in front of scapula, the pull will be from front. If the pull is from front, which rotation it will be doing? Yes, if you can tell me. If the pull is from front, it will be doing the medial rotation. It will be doing the medial rotation. In a similar manner, if we see the other muscles, we can see infraspinatus and teres minor. These are the muscles pulling from behind. If the pull is from behind, which rotation it can do? They can do the lateral rotation. Are you able to follow? Now you see another muscle which is present above. Now for this muscle, the pull is neither front nor behind. If the pull is neither front nor behind, it will be not doing any rotation. It is non-rotator. But what will be its action? Action is above, so it will be pulling here. Thus, the humerus will move up like this. If the humerus moves up like this, it is called as abduction. It is going away from the axis. It is called as abduction. Abduction from 0 to 15 degree will be done by the supraspinatus muscle. So again, as I said, dear friends, that we have to understand the anatomy in such a way that what we can visualize, what we can think ourselves, and what we can think of the actions and all, we don't have to mug up, okay? We have to integrate this part with the clinical aspects also. I hope this much part is clear, right? Now, dear friends, I'll take one more topic and I'll explain that in some of the areas, we will be taking the help of the mnemonics, okay, to remember the structures. How we can do that? Let me show you. So we are looking at a muscle who is present in front in the chest region, which is called as pectoral region. So this muscle, what is the name of the muscle? This is pectoralis major muscle. This is pectoralis major muscle. And what will be its action? Now we can think that if the muscle is in front, it can do flexion or extension. Obviously, if the muscle is in front, it will be doing the flexion. Another point, when the muscle pull is coming from the medial aspect, it will be pulling the humerus towards it or away from it. It will be pulling towards it. So that means it will be doing the adduction also. And the last thing, because the pull is in front, will it do medial rotation or lateral rotation? We have just now discussed front from the pull will be coming from the front. That means there will be medial rotation. So we can say there will be these actions, that is flexion there will be adduction, and there will be medial rotation also, right? There will be medial rotation, okay, like this. So these are the overall action of the muscle, right? We can say that. But this muscle is present in front, and it is kind of bounding this part which we call it as axilla, which is gateway for the nerve and vessels of the axilla. What is axilla? This is the gateway for the nerve and vessels of the upper limb, because the nerves and vessel have to reach the upper limb part. This is the upper limb, right? So the nerve and vessels will pass through the axilla, where the anterior boundary made by this pectoralis major. And what are these muscles? This muscle is called as latissimus dorsi, which we have already seen in the previous discussion. We have seen the latissimus dorsi, we have seen the trapezius also. What is this muscle? This particular muscle, if you see this particular muscle, this much is the teres major. This is teres major muscle, and in front we can see this triangular gap is there. Now this triangular gap will be filled by the muscle in front of the scapula, because in front of the scapula we have subscapularis. You remember, subscapularis will be in front. So the concept I have already discussed. Now it becomes easy for you, right? So we can simply write down, this will be subscapularis muscle. This will be subscapularis muscle. I hope that makes sense. So these are the boundaries, anterior and posterior. But let me show you the axilla in section. When you see the axilla in section, let me explain. We have pectoralis major muscle that is in front, and pectoralis minor also behind. But pectoralis major and minor together, they make the anterior wall for the axilla. What is behind? This is the subscapularis muscle along with teres major and the latissimus dorsi. Medially we have the ribs, and over the ribs we have serratus anterior muscle, and laterally we have the intertubercular sulcus region of the humerus bone. But inside we can see the axillary sheath, which is surrounding the axillary artery, brachial plexus, the cords of the brachial plexus, that is nerve, and the vein also. But the point here is important point, that axillary sheath thickness is not same around all the structures. Around the vein it is little thinner to allow the expansion of the vein. Okay, but that much detail we will learn later. For time being, we can understand about these structures which are present here. Particularly, I would like to discuss the axillary artery branches. I would like to discuss the axillary artery branches. Now, how to remember the names of the axillary artery? We will take the help of mnemonics. So here we have axillary artery, and axillary artery is divided into three parts. Axillary artery, it is divided into three parts. By which muscle? It is divided into three parts by pectoralis minor muscle, by pectoralis minor muscle. Here you can see this is the pectoralis minor muscle. This muscle is the pectoralis minor muscle. Let me show you in the diagram. This is the axillary artery which is passing behind this muscle. This muscle is pectoralis minor. So we have axillary artery. Proximal part will be called as part 1. Behind we will be calling it as part 2, and distal part will be called as part 3. So the same artery, it is passing behind the muscle. We'll say part 1, part 2 behind, and part 3 is here. So three parts of the artery. What are the branches from these parts? So we can say first part, second part, and third part of the artery. We have first part, second part, and third part of the artery, and the names we can remember by using a mnemonic. Our mnemonic is salt spa. Salt spa. Now that is a mnemonic. How to use this? So remember this point here. We will put the T in a dotted line because D is common. How to use, I will explain. So from the first part, S for superior, S for superior, S for superior, and add T. T is common, right? I said T will be used common. So superior, T will become like thoracic. So it is superior thoracic. Then what is A? A is acromio, acromio. And again that is thoracic. So it became acromiothoracic. Then L is lateral, and again we will put T, that is thoracic, lateral thoracic, right? In a similar manner, we can easily remember now that superior thoracic, acromiothoracic, lateral thoracic. But what about the SPA? SPA part here is we have subscapular, then we have pacha, and then we have acha. Now it is easy way to remember when we say pacha acha. But what is pacha acha? Let me write the full form, because to understand ourselves we can use the short form, but actually we have to learn proper names also, and in the exam we have to write proper names only. Okay, since these mnemonics and things, it is making the stuff easy for us, right? So what is pacha and acha? That is posterior circumflex humeral artery, that is posterior circumflex humeral artery, posterior circumflex humeral artery, and this one will become anterior circumflex humeral artery, like that. So this is the complete name. Now we can see, right? So it is relatively easy. Otherwise we have to memorize all the branches names. So but we use that, we take the help of mnemonic salt spa. It became relatively easy for us, right? So that was one thing. Okay, and now let me also explain one more muscle, that is serratus anterior. Why? Because I would like to show you one clinical aspect. Okay, so this serratus anterior is coming from the chest wall, but then it is also attached to the scapula bone. In this view we can't see the complete attachment, so we will take the help of another diagram. When we take the help of this diagram, here we can see the muscle is attached to the chest wall and also attached to the scapula. But how it is attached, this is important for us to understand. The muscle is coming from the outer aspect of the chest wall, that is outer aspect of the ribs. But when it is approaching the scapula, it is going all the way up to this medial border over here. What is the point of having such attachment? When the muscle will contract, over here, we can say when the muscle will contract in this direction, okay, in this direction, when the muscle will contract over here, this will make the scapula sweep forward. This will make the scapula sweep forward around the chest wall. The scapula will come forward. With the scapula, the arm is attached. The arm will come forward. That is required for the boxing, for the pushing, punching. That's why the serratus anterior is called as the boxer's muscle. That is the name, you can say the fancy name as per the action. The action is the boxing. That's why the name of the muscle is the boxer's muscle. All right. And what is the clinical input that I wanted to discuss here? See, the nerve supply of the serratus anterior is the long thoracic nerve, and sometimes there is nerve injury. In case of the nerve injury, the muscle will become paralyzed. If the muscle is paralyzed and the patient comes to you, you ask the patient to push against the wall. Now, pushing is the action of which muscle? It is the action of this muscle serratus anterior, which is attached to the medial border of the scapula. Now, pushing is not possible because serratus anterior is not working. So what will happen? The muscle where it is attached, that part of the scapula will become prominent. The medial border, the inferior angle, that becomes prominent, and this is what is called as winging of scapula. So we can see this feature, winging of scapula, right? We will get this feature, winging of scapula, in case of injury of the nerve, right? This is called as winging of scapula when the serratus anterior is not working. And why it is not working? Because of the nerve injury. So basically we have to integrate the actions with the clinical application also. I hope you got the point, dear friends. So with these few points, what I try to explain is always we should have a comprehensive understanding, conceptual understanding, which we can integrate with the clinical application also. Why this is important? Because at the end of the day, you will be sitting in an OPD and the patient will come to you. Then you have to apply all the knowledge that you have gathered all throughout this 5.5 years, including the internship, right? So all throughout this period, what you have learned, you should be able to integrate when you are examining the patient, when you are treating the patient, right? So now here, what we are offering, we have the specifically tailored classes for the first year MBBS students, okay? And because we want to give you the conceptual understanding in the fields of anatomy, physiology, and the biochemistry, okay? Those will be basic concepts, conceptual understanding, which can be integrated in your with the clinical aspects also, right? So we have the India's only live two-way interactive course for the first year MBBS, Why I'm saying so? Because if you are learning live with us, if suppose I am teaching here and in this today's topic, like if you have some doubt, like what is the meaning of this muscle, what is the action, why is this action, now how will you ask me? But if we are connected live, so it will be going two-way. I can interact with you, you can interact with me, right? So we have interactive two-way class, so your doubts will be solved instant then and there. You will ask me the doubt, I will immediate reply. So your doubts are solved. So there is no pending, right? No pending thing to do. And another important thing here, that how we will proceed, we will be proceeding like, we know that you have been attending the classes also in your college, right? So we will be taking like 4 to 5 classes in a week, and those classes will be all of around 1.5 hours. So 1 hour 30 minutes, that means, okay, these classes definitely will give the extra edge, because you can learn with us in this manner that I have taught right now. And also because some of you would like to read way beyond like the classes at the pace you want to go beyond that, or maybe like in different colleges we have different sections starting, like some colleges will start with the upper limb, some colleges will start with the lower limb. So to understand that way, we will also provide you additionally, see, live classes will be there, all the course will be completed live. Additionally, we will provide you with the recorded access of the previous cycle which we have done with your senior batch, okay, so that you will be having the recorded videos also. At any time you can play any video, but live we will follow one format and we will go through all the sections, okay. So that is something very, very important. As I said, with the great achievements come great responsibility. You have to understand that we have to deal with the human lives, so you have to learn in a proper way, dear friends. And always in your life be sincere, and always please remember, if you do not sacrifice for what you want becomes a sacrifice. Why this is important? Because we have, you see, entered the field of medicine. That's a very wonderful word. That's fine. But this MBBS is the beginning, and we have to go for so many heights, right? Many of you would like to become, you see, cardiologists. You would like to work in with the prestigious hospitals like Apollo, Medanta, AIIMS, right? Many of you would like to become neurosurgeons and what not. So sky is the limit. For learning, there is no end, right? So that is very, very important for us to understand, that we have to work hard, we have to be sincere in our studies, in our work, okay, dear friends. So this is me, Sandeep Madan. This is my contact detail. If you have any doubt regarding any of the issue, right, you can be in touch with me. I would love to help you as soon as possible. God bless you all. Thank you.